Dear colleagues, first of all, I'd like to thank SEMA, in particular Dr. Nabil Amuradin, for choosing our department for this update in diabetology. I bring you the greetings for my chief, Dr. Pacagnella, and my General Director of Treviso Hospital, Dr. Benazzi. Thanks to Informatici Senza Frontiere for the precious technical support, and Patient Diabetic Association for Treviso, who introduced me to Dr. Almuradin, and thus was born this project. Finally, thank you so much that you are here, so many of you, and I hope that this training course will be useful in your clinical practice in a difficult context you are forced to live in these years. My colleague, Dr. Mauro Rigato, who is here, right here with me, will support me in these lessons. Okay. We have a problem, sorry? Ok.
Scusa, non si vede il video. Non si vede il video, la tua foto si vede.
Yeah? Vedi?
La tua foto. La tua immagine.
Do you see the slide?
The slide?
Nabil, si vedono solo le slide, Nabil.
Va bene, va bene.
Okay. The objectives of this course are summarized in this slide. At the end of this update in diabetology, we will let you be able to make an early diagnosis of diabetes, manage cardiovascular risk factors, prevent diabetes and obesity, screen diabetes chronic complications, and manage diabetes with new health therapies, and manage diabetes during Ramadan, and report outpatient in database. I don't know if Dr. Almoraben should be giving you a database to register out patients. I don't know if Nabil, you give them the database I give you in last week.
I will give him after the conference.
Okay. This is important for us to receive information of the most common type of diabetic patients in your countries. We can therefore evaluate how many diabetic patients you visit, the complication, and the therapy they take. We'll see each other again in June, and after a month, we will give you a learning test. You could also propose clinical cases to be solved together if you want. Finally, a certificate of attendance will be issued to you. And today we'll talk about two parts. In the first part, Dr. Mauro Rigato talks about diabetes and classification and life management. I speak about Ramadan guidelines. So, Dr. Rigato, please, let's start with the presentation. Okay.
Okay. So good afternoon to everybody, and thanks again to participate to this lessons about diabetology. And I want to start our cycle of lessons with a short agenda about the items we speak to today. And I want to start speaking about the classification of diabetes, the diagnostic criteria to do the diagnosis of diabetes, and about the glycemic targets that we have to achieve in our patients. And finally, I want to spend some words to speak about lifestyle management and in order to prevent the development of diabetes in high-risk patients. So many of the information and of the guidelines I will show you in the next slides are taken from the Standards of Medical Care in Diabetes published by the American Diabetes Association, and as you can see, they are really updated to this here. So let's start with the classification of diabetes. In summary, we can identify 4 different kinds of diabetes. The type 1 diabetes, that is an autoimmune disorder characterized by the destruction of beta cell in the pancreas. The type 2 diabetes, that is a complex metabolic disorder that is characterized by a systemic insulin resistance leading to a progressive insulin reduction from pancreas. We can identify the gestational diabetes, that is a particular kind of hyperglycemia that is recognized during pregnancy. And finally, we can identify some other types of diabetes that we can call as secondary diabetes, and they included the monogenic diabetes syndromes, that are monogenic disease characterized by a deficit in genes involved in insulin secretion in pancreas. Then we can identify some kind of diabetes secondary to exocrine pancreas disease, such as inflammation of pancreas or pancreatic cancer. And finally, one of the most common cause of secondary diabetes, that is the steroid-induced diabetes. Okay. Starting from the classification, I want to show some the diagnostic criteria to perform diagnosis of diabetes. And as you can see in this slide, we can do diagnosis of diabetes when we have at least one of the following 4 criteria. The first one is fasting plasma glucose equal or higher than 126 milligrams per deciliter. The second is a 2-hour plasma glucose after an oral glucose test equal or higher to 100 milligrams per deciliter. The third is an HbA1c equal or higher 6.5%. And finally, we have 4 criteria that is a random glycemia equal or higher 200 milligrams per deciliter in presence of typical symptoms such as polyuria or polydipsia or weight loss.
Scusa,
Sì.
Mauro.
Non ti sento.
C'è qualcuno
che chiede?
Mi-
No, non ti sento. I can't listen to you. Puoi mandarmi un messaggio. Could you give me a message? Send me a message by chat, in the chat. Oh, va bene, ok.
Comunque dopo che parli italiano.
Sì, vabbè, parliamo in italiano. Ma li vede se io scrivo? Tipo se io scrivo non ti sento.
Però devi scrivere. Non trovarlo qua.
Non semplice cosa.
Perché dovi?
No.
Vabbè.
Ciao. Nabil?
Sì. No.
Mi senti? Dimmi pure la domanda, vediamo se riesco a sentirti.
راح الصوت ما عادش شغال هذا. Mi senti adesso?
Sì, adesso sì, dimmi.
Ah, ecco, ti stavo dicendo, qualcuno chiede se possiamo tradurre in arabo. Allora,
Sì.
fa,
Vuoi che parlo più piano?
Ecco, se poi ogni tanto magari fai
Una pausa.
e traduci la dottoressa in arabo.
Ok, va bene.
Grazie, grazie.
Niente. Okay, so I will speak slowly in order to permit you to translate. Okay.
تمام. الموضوع
Yes.
المواضيع اللي تناقشت هي
So
تصنيف الداء السكري
andare avanti?
Su questo.
No, la prossima slide.
Scusa.
Ok.
تصنيف الداء السكري نحن المعروف عنا في
So I wait a minute. Aspetto. Ok.
Facendo la sintesi di quello che hai detto fino adesso.
Ok.
الثالث هو الداء السكري الحملي اللي بيظهر بوسط الحمل. الداء اللي فيه وفي الداء السكري بعدين عن تشخيص الداء سكر الدم على الريق أكثر أو يساوي سكر الدم أكثر من 200 ملغ والانخفاض الجلوكوزي
Dr. Nabil, the sound is not clear. Dr. Nabil, the sound is not clear.
Non è chiaro? Non è chiaro? Pronto?
Sì? Mi sentite?
No, noi sentiamo benissimo voi.
Noi un po' a pezzi, a tratti.
Ah, vabbè, mi dispiace, quello...
Possiamo andare avanti?
Possiamo andare avanti?
Allora, sì, poi, però...
Magari? Sì?
Finisce la slide?
Ok?
دابا هلا كنا السلايد انت بعد بالعربي هن بالانجليزي
تمام.
puoi cominciare.
Okay. I presented you in the previous slide the diagnostic criteria for diabetes, and in this slide I want to remark the importance of another condition that is called pre-diabetes. And with this term, we identify three different conditions that are not diagnostic for diabetes, but they are at very high risk to develop future diabetes. And in particular, we can identify the first condition that is called impaired fasting glucose, and is characterized by fasting plasma glycemia between 100 milligram per deciliter and 125 milligram per deciliter. The second condition is called impaired glucose tolerance, and is characterized by 2-hour plasma glucose during an oral glucose test between 140 milligrams per deciliter and 199 milligrams per deciliter. And finally, we can identify a third condition characterized by a level of HbA1c between 5.7 and 6.4%. Remember that for all these three conditions, the risk of development future diabetes is continuous during all the range of the glycemic value.
بعد ما
والله الحمد لله.
غير الصالح في الخضار الجلوكوزي إذا كان الخيار 140 وال 109 خضار الجلوكوزي بين الخمسة.
ما في داعي للترجمة العربية، ما حدا عم يسمع شيء. من دون ترجمة.
Please continue in English, please.
Can I continue?
Allora continua in inglese, dicono che non sento l'arabo. Vabbè.
Dr. Nabil, the sound in Arabic is not clear.
Please continue in English.
Okay, I will continue in English.
Allora continuate pure in inglese, ok.
Okay. I try to speak slowly if it could help you to translate, okay, in your language. So here I present some important clinical differences between type 1 and type 2 diabetes. You can see as the onset of diabetes is different, is sudden in type 1 and is progressive in type 2 diabetes. And usually type 1 is characterized by a dramatic onset, often ketoacidosis, that is an emergency, a medical emergency. And you can see also as is different the age at onset, that is young for type 1 and is the adult age in type 2. And we have other differences. For example, the body weight that is normal, usually in type 1, and is high and in the obese range, often in type 2. And the last difference is the positivity for the pancreatic autoantibodies that are usually present in type 1 and absent are clearly absent in type 2. Do you translate? Could I go on the next slide?
We go home.
Yes, please go on.
Okay.
Ma avete detto
So in this picture, you can see the natural history of type 1 diabetes. That I repeat is an autoimmune disorder. So some patients that are with a genetic predisposition after a precipitating event such as a viral infection, for example, could develop an autoimmune disruption of beta cell mass, leading to a progressive loss of insulin secretion capacity, and in parallel leading to a progressive hyperglycemia until the overt of diabetes. And it's very, very important to looking for the pancreatic autoantibodies. We have to detect the pancreatic autoantibodies in type 1 diabetes, where the most sensitive is the autoantibody against the glutamic acid decarboxylase. Usually here we will check for other autoantibodies, other pancreatic autoantibodies against the islet cell cytoplasmic and against the protein tyrosine phosphatase. But remember, the most important is the autoantibody against the glutamic acid decarboxylase. And another key concept, another important concept I want to give you is that the autoimmunity often cluster together different diseases, and so the type 1 diabetes is often associated with other autoimmunity, in particular with autoimmunity against thyroid, against the bowel, such as the celiac disease, and we can also find some case of Addison disease and of autoimmune gastritis. So when we find a patient with a type 1 diabetes, we have to screen for other autoimmune disease. It's very, very important, especially for the thyroid. And in the previous slide, I told you that type 1 diabetes usually onset in the young people, but this is not always true, because we have some form of latent autoimmune diabetes where the onset of diabetes, of the autoimmune diabetes, is in the adult age. And so we have to detect this form of diabetes, because it has been estimated that they account for the 10% of patients that we usually diagnose it as type 2. And you can see the diagnostic criteria for latent autoimmune diabetes in the adults. At diagnosis, patient usually should be at least 30 to 70 years old. We have to have the presence of at least one pancreatic autoantibodies, usually the anti-GAD, and the patient at least have to remain 6 months without the need of insulin. On the other side, we have the type 2 diabetes. That is a complex disorder, as I told you, and is the consequence of systemic insulin resistance. In other words, the tissue of the patient are resistant to the action of insulin. And the insulin resistance is responsible not only of hyperglycemia but also of other metabolic abnormalities such as hypertension, for example, problems with the lipid profile, and of abnormal accumulation of fatty in the liver. And together, all these conditions represent important risk factors for heart disease, so for cancer and for development of dementia, for example. And they could be clustered together in the context of this condition that is called metabolic syndrome. I don't want to bore you, but these are the criteria to diagnose this metabolic syndrome. And you can see as the most important criteria is the detection of central obesity, and we can identify obesity by the evaluation of body mass index or of the weight circumference of our patients. So these are simple measurements to perform also in our outpatient setting. And the central obesity should be accompanied by at least 2 other following factors, such as the increased blood triglycerides more than 150, a reduced level of HDL cholesterol, that is the good cholesterol, less than 40 milligram per deciliter in males and less than 50 milligram per deciliter in women. We have also hypertension and an impairment of fasting plasma glucose. So if we have a central obesity plus any 2 of the following criteria, we can speak of metabolic syndrome. And it's very important to detect obesity. I don't know in Syria, but here in Italy and also in Europe and United States, obesity represents a pandemic problem, and the prevalence of obesity is increasing dramatically. It's really simple to make diagnosis of obesity. We can measure the body mass index, that is the ratio between the body weight and the square of 8 in meters. And if we will find an BMI equal or higher 30, we can diagnose our patient as obese. But the BMI did not tell nothing about the distribution of fat, because we can have 2 different distributions of fat in our patient. We can have an apple-shaped distribution that usually is characteristic of metabolic syndrome and is associated with a high cardiovascular risk. And on the other side, we could have a female or pear-shaped distribution of obesity that is characterized by an accumulation of subcutaneous adipose tissue and is less commonly associated with other metabolic abnormalities and with cardiovascular risk. Here I presented the glycemic targets that we would like to achieve in our diabetic patients, and they are taken from the American Diabetes Association guidelines. You can see there is a median level of HbA1c of 7%, that was considered in the past as the only target for a good glycemic control. But nowadays the perspective is completely changed, and it's more important to individualize the target for a glycemic control, and so we can achieve a less severe control in patients with long duration of diabetes or with reduction in life expectancy or important comorbidities or cardiovascular disease. And on the other side, we have to achieve a more severe control in patients with young age, without comorbidities, and in all those the patients taking agents and drugs with low risk of hypoglycemia. As you remembered, I show you in the first slide the gestational diabetes, that unfortunately is a common kind of diabetes that we found in our pregnant woman, and is defined as diabetes first diagnosed in the second or third trimester of pregnancy in patients that have not a pre-existing diagnosis of type 1 or type 2 diabetes. And it's very important to detect gestational diabetes, because hyperglycemia during pregnancy is associated with a higher risk of maternal complications such as preeclampsia, cesarean delivery, infections, polydraminus, and especially with some important fatal complications, and in particular with macrosomia, with an excessive growth of the child. Here you can see the screening approach for gestational diabetes, that is very different depending on the different country where you work, but this is the one-step approach that is proposed by the American Diabetes Association. And you can see as all the women should be without a previous diagnosis of diabetes should be underwent an oral glucose test with 75 grams of glucose at 28 weeks of gestation, and if at least one of the following cutoff for glycemia are higher than those I reported in the red box, we can perform a diagnosis of gestational diabetes. And so the woman should undergo a diet program, and if is not controlled by the only diet, should undergo insulin therapy. And the therapy is aimed to achieve the following glycemic targets during pregnancy, that are fasting plasma glycemia lower than 95 milligram per deciliter, and 1 hour postprandial glucose lower than 140 milligram per deciliter. So let me spend only few words to speak about the prevention, the importance of prevention diabetes, because it's very important, especially in people with pre-diabetes, to to reach some lifestyle changes in order to reduce the risk of development of diabetes. And this was clearly shown by an old study that was published in the northern of Europe and is called Diabetes Prevention Program, where 1,000 patients with pre-diabetes were randomized to only lifestyle management or to metformin treatment or to placebo. And as you can see, the risk of development future diabetes was significantly lower in patients with lifestyle management compared to the drug, the metformin. And this is a very important message because we can do a lot of work only with diet and with physical activity, and the reduction in the glycemia with the lifestyle management should be higher than those obtained by metformin. And the principal lifestyle changes we have to focus are the nutrition, and in particular we have to reduce the simple blood sugar, and the physical activity. We have to increase the physical activity of our patient, and our patient should undergo to at least 150 minutes of physical activity per week. And it's very important to encourage our patient to smoking cessation. Finally, this is one of the last slides. It's very important to treat not only hyperglycemia, but also the other component of the metabolic syndrome. And so if we treat together hypertension, hyperglycemia, hypercholesterolemia, we encourage the weight loss. The effect in terms of reduce the all-cause death of our patient is really stronger than the effect that we should obtain treating only hyperglycemia. And this is a very, very, very important issue. And this issue is remarked by all the international guidelines. Here I'll present the guidelines of the American College of Clinical Endocrinologists, where you can see how we have to reduce our level of LDL cholesterol lower than at least 100 milligrams per deciliter, but in the most part of our patients at very high risk, and the very high risk is defined by the presence of diabetes and only another risk factor such as hypertension, the cutoff is lower 70 milligrams per deciliter. In patients with the previous event, this target is lower again, under 55 milligrams per deciliter. On the other side, it's very important to treat hypertension, and in particular, we have to reduce our systolic pressure lower than 130, and our diastolic pressure under lower than 80 millimeter of mercury. So I want to thank for your attention. I'm sorry for the the problems in the translation and about the quality of audio. And I want to show you this picture that is one of the picture of our city, Treviso. That is very nice. It's like a small Venice. Thank you very much again.
Thank you. Thank you.
The question at the end? Okay?
Okay.
Okay. Okay, the second part of this presentation is about Ramadan guidelines contents. I talk about firstly physiology, risk stratification, disease management, and the conclusion. It's clear the importance of effective guidelines for the management of diabetes during Ramadan fasting. The ones I show you are guidelines written by International Diabetes Foundation in collaboration with Diabetes and Ramadan Alliance. Guidelines provide practical recommendations on how to optimize the care to patients with diabetes who plan to fast during Ramadan. These recommendations are approved by the Mufti of Egypt, the highest religious authority in Egypt, as well as being a scholar of Al-Azhar, one of the globally famous Islamic academic organizations. About physiology. These figures I show you describes the typical sleeping eating patterns of Muslims in many countries during Ramadan and in non-Ramadan periods. However, in other countries, many Muslims may be awake most of the night and asleep after dawn, as no food or drink is taken during the hours. And the time between meals during Ramadan is much longer than in the other months of the year. This has important implications for physiology, with changes in the rhythm and magnitude of fluctuation in several endocrine processes. The impact of Ramadan on sleep includes decreased total sleep time, delayed sleep, decreased sleep period time. Sleep deprivation has been associated with decreased glucose tolerance, and the correlation between sleeping duration and insulin resistance has been a subject of medical interest. So, changes to sleep and food intake impact on circadian rhythms. Several changes have been noted, including in cortisol levels. Compared with non-Ramadan periods, lower morning cortisol levels and higher evening cortisol levels have been observed. It's an adaptation mechanism to the stress. Alteration in cortisol circadian rhythm may account in part for the feeling of lethargy felt during Ramadan. It's like the day is reversed with the night, okay? So how does fasting any problems? So how does fasting affect any problem? I go on.
No, you carry on,
Okay. So how does fasting affect patients with diabetes? So it's important to know in healthy individuals, increased glucose levels in the blood after eating stimulates insulin secretion, which triggers the liver and muscles to store glucose and glycogen. Liver glycogen can provide enough glucose for the brain and peripheral tissues for around 12 hours. When glycogen stores are depleted and levels of insulin are low, fatty acids are released from adipocytes and oxidized to generate ketones, which can be used as fuel by many organs, preserving glucose for the brain and the erythrocytes that are unable to use ketones. In individuals with diabetes, glucose homeostasis is disturbed by both the underlying pathophysiology and the medication used to treat the condition. When fasting, insulin resistance or insulin deficiency can lead to excessive glycogen breakdown and increased gluconeogenesis, with risk of hyperglycemia and ketogenesis. And now it's problems for the slides. We have a problem for the slide. Because the slides is different. Because the slides is non è questa qua.
Perché è su PDF e questa è su PowerPoint e su PDF non uguale.
No, ma io l'avevo tolte. I don't know. So the slides is different, but the consequence of fasting during Ramadan is not only thrombosis, as you see, but the consequence of fasting are described. It includes hypoglycemia, hyperglycemia. Hypoglycemia is due to reduced caloric intake and anti-diabetic medication. Hyperglycemia due to excessive reduction of anti-diabetic medication, carbohydrate-rich meals, excessive glycogen breakdown, and increased gluconeogenesis. The other consequence of fasting during Ramadan is dehydration due to reduced fluid intake, osmotic diuresis linked to hyperglycemia, and thrombosis due to hypercoagulability and increased blood viscosity. And not least, ketoacidosis due to increase to ketogenesis, in particular in type 1 diabetes. During the fast, in particular in patients with type 1 diabetes, during the fast, patients with type 1 fail to secrete adequate levels of glucagon in response to hypoglycemia, leading to decreased blood glucose levels. In addition, as a result of autonomic neuropathy that we'll discuss in the next lessons, some patients with type 1 diabetes may have a defective adrenaline response and therefore an inadequate response to hypoglycemia. A minority of patients have increased risk of severe hypoglycemia and hyperglycemia that requiring hospitalization. The incidence of severe hyperglycemia were also found to be increased during Ramadan, 3-fold and 5-fold in patients with type 1 and type 2 diabetes respectively. Risk stratification is important, is very important before Ramadan. To set and consider the factor risk quantification are summarized in this slide. And in particular, you have to consider type of diabetes, patient medications, individual hypoglycemic risk, presence of complication, individual social and work circumstances, and previous Ramadan experience. In this table summarizes the new risk categorization defined by IDF and Diabetes and Ramadan International Alliance. All patients are instructed to follow medical advice and should not fast if the probability of harm is high. Patients who are in the two other categories of risk, the category 1, very high risk, and category 2, high risk, are advised not to fast. However, many of these patients will choose to do so, and this must be respected, okay? Once a patient has been made aware of the risk associated with fasting, they should be provided with an individualized management plan and be advised on the measures that can take to minimize this risk. People with type 1 diabetes is in a very high risk of category, and religion leaders do not recommend fasting individuals with type 1 diabetes. In particular, patients with type 1 who have any of the following conditions. So, with history of recurrent hypoglycemia, hypoglycemia unawareness, or poor diabetes control, brittle diabetes, diabetes who has a high variability of blood glucose, or patient non-compliance with medical treatment, or who are unwilling and unable to monitor and manage their blood glucose levels. Pregnant women are advised not to fast because we have no data available to support any change in this category. Older people old age is not considered an additional risk for fasting, but we have to consider old age combined with ill health. So only old age with ill health is in a very high risk to fast. Probably the problem is correlated for hypoglycemia. So it's important knowing which anti-diabetic agent the people take. And summarize risk stratification, we resume here with the risk associated with fasting include hypoglycemia, hyperglycemia, dehydration, thrombosis. It's important, it's very useful, the risk stratification approach proposed from IDF and DAR Alliance, and defines the 3 risk categories. It's useful for you knowing the 3 risk categories, all the pathology present in these categories. Patients who fast against the advice provided by their HCPs should follow expert detailed guidance to avoid the development of serious complications. About disease management. All patients with diabetes who wish to fast during Ramadan should prepare by undergoing a medical assessment and engaging in a structured education program to undertake the fast as safely as possible. This assessment should take place 6-8 weeks before Ramadan. So now we are just in late. I don't know when Ramadan begins. Nabil. Next week? Next week?
16.
16, okay.
Yes. When?
Okay. So we are late for the pre-Ramadan assessment.
Yes.
Okay. In pre-Ramadan education, is very important. In pre-Ramadan education, there are key components to remind. In particular, blood glucose monitoring. There is a misconception held by some Muslim communities that pricking the skin for blood glucose testing invalidates the Ramadan fast. It should be strongly emphasized in educational programs that this is not true. Checking blood glucose levels is an essential component of diabetes care, and patients should be provided with the tools and knowledge to carry out self-monitoring of blood glucose. Having the skills to self-monitor blood glucose levels can empower patients with diabetes to effectively self-manage their disease. So blood glucose monitoring is important. When you're monitoring blood glucose levels, doesn't mean breaking fast, okay? It is important for identifying and preventing episodes of hypoglycemia and hyperglycemia. Is useful for guidelines. Okay? Useful for guiding those titration medications. And the frequency of self-monitoring blood glucose depends on the type of diabetes and medications. If the patient is in a high-risk category, he will have to check the blood sugar several times. In some cases, up to 7 times a day. If the patient is allowed to fast, he can check the blood glucose 1 or 2 times a day.
يا دكاترة بدنا نسمع المحاضرة.
So, when to break the fast is clear. There are 2-3 conditions in which all patients should break their fast. When blood glucose is lower than 70 milligrams per deciliter, and in this situation, recheck within 1 hour if blood glucose is 70-90 milligrams per deciliter. And the patient should break their fast if blood glucose is up to 300. Okay, how hard there are symptoms of hypoglycemia, hyperglycemia, or dehydration. The symptoms of hypoglycemia you could read here. And for hypoglycemia, you feel trembling, palpitation, hunger, altered mental status, confusion, headache. When you are in hyperglycemia, you feel also hunger, but also frequent urination, fatigue, and extreme thirst. Okay, nausea and vomiting. In some cases, abdominal pain. Fluid and dietary advice. It's important during Ramadan, during fasting. It's important when you are in sahur or at iftar, drinking water, drinking not sweetened beverage. And it's important to divide daily calories between sahur and iftar. Plus, if you want 1 or 2 snacks, okay, the meals are well balanced. So 50% carbohydrate, maximum 30% of protein, on a minimum of 30–35% of fat. You have to prefer food with low glycemic index, high fiber foods that release energy slowly before and acting faster. Include plenty of fruit, vegetables, and salads. Minimize food that are high in saturated fat. Attention, avoid a sugary dessert, okay? And avoid caffeinated and sweetened drinks. The Ramadan, this is a website and where you could build a Ramadan nutrition plan. The Ramadan nutrition plan helps patients with diabetes to plan a daily caloric target that may help them to maintain body weight if they are lean, or to lose weight if they are overweight or obese. You can see an example from Ramadan Place, for example. You have a caloric guide for weight reduction or weight maintenance. You are the access of the online version. If you go to this website, you find all the information, and it's possible to create an example Ramadan plate, a balanced Ramadan plate, and you can give to your patient a plan, like a guide. This is a toolkit with a menu example, and you find a target daily calories, macronutrient composition, and distribution caloric in the day, and you find a typical menu, and it's useful if you want to create a menu for your patient during the Ramadan. About disease management. Regarding the drug therapy, we will speak specifically in June. Here I report the drugs in general and the dosage changes during Ramadan. Metformin is among the therapeutic options, is the most commonly used first-line oral antidiabetic drug and works by preventing the liver from producing new glucose. It comes in an immediate release preparation, which may be taken up to 3 times a day, and a prolonged release formulation, which is typically taken just once a day. It is considered safe for individuals on metformin to fast because the risk of hypoglycemia is low. The tables can be taken at iftar if the patient takes once daily dose or if the patient takes prolonged release dose. If they take twice daily, take at iftar and sahur. If the patient takes 3 times daily dosing, the morning dose will be taken before sahur and combine afternoon dose with the dose taken at iftar. These are the second-line treatment for type 2 diabetes. Is sulfonylureas. Sulfonylureas are widely used for type 2 diabetes after metformin and stimulate insulin secretion from pancreatic beta cells in a glucose-independent process. Because of this, sulfonylureas are associated with a higher risk of hypoglycemia. More recent sulfonylureas such as glimepiride, glipizide, and gliclazide are therefore preferred over conventional sulfonylureas as glibenclamide because of their more favorable safety profile in terms of hypoglycemia. If patients take a short-acting secretagogue or sulfonylurea like repaglinide 3 times daily, the dose may be reduced to 2 doses, and they can be taken before iftar and sahur. At iftar, they can be taken full dose of their repaglinide and at sahur half dose. If it's possible, the older drugs in the glass should be avoided. Is not used the older drugs like glibenclamide for the high risk of hypoglycemia, but prefer gliclazide. In the last 10 years, diabetes therapy has been enriched with new drugs we will discuss in detail in the last lesson. These include incretin therapy with GLP-1 analog and DPP-4 inhibitors. I don't know if you have patients with this treatment, this new class of oral antidiabetic drugs. So I don't know, Nabil, if you can ask to the public if have patient with kind of therapy, because we talk about these drugs in the last lessons. So I don't know is useful for you. Talks about
here.
Okay, okay. So for your knowledge, we talk about this new class in the last lesson. Okay.
It's not
so I'm going
here. For the medication GLP-1 agonist.
Okay. Is not this
in
and
Turkey
DPP-4
does not exist.
Does not exist.
In
And
Syria, I think it not exist too.
Okay, okay. Let's go on. Insulin treatment for type 2 diabetes. Is it ethics?
Yeah, I think so. It's available for use inside Syria. This insulin.
Okay.
Yes.
Okay. Okay. Insulin treatment for type 2 diabetes and also for type 1 diabetes may include the use of long and intermediate acting basal insulin like glargine, detamir, or NPH insulin, and short-acting bolus pre-meal insulin like Lispro, Aspart, or regular human insulin. Insulin used during prolonged fasted carries and increased risk of hypoglycemia. Is recommended the use of insulin analog because respect the human insulin, the insulin analogs are a less risk of hypoglycemia. Do you have in your countries analog of insulin analog?
No, we don't have.
We don't have.
Yes, the medication of
only human insulin.
We have rapid insulin, rapid acting insulin.
هي بتسأل أبيدرا سوري هي بتسأل عندنا في سوريا في أبيدرا ولانتوس.
Lantus?
In Syria,
okay.
I don't know.
Available. I think it's available. It's
available Lantus. Okay.
No, we don't have in Syria. Yes, we don't have Lantus.
It's available.
Okay, Lantus in Syria, no, in Turkey. Okay. Okay. Okay, so you have glargine that is named Lantus, and like long-acting insulin, or NPH, so intermediate-acting insulin. In this case, so if you have patients during Ramadan that takes glargine or NPH or intermediate acting insulin, you have to reduce dose by 15–30% and take this dose at iftar. And if take intermediate insulin twice daily, they take usual morning dose at iftar and reduce evening dose by 50% and take at sahur. For the short-acting insulin, which kind of short-acting insulin you have? Lispro, Humalog, or Novorapid, Humulin Hair,
Rapid insulin.
All? For short-acting insulin.
Yes, rapid.
Okay. For short-acting insulin, you have to take normal. You can take normal dose at iftar and reduce sahur dose by maximum 50%. And for do you use Premix Insulin? Is a common use for you Premix Insulin?
Yes.
Yes.
Okay.
It's the most.
Okay, it's most common. Okay.
70 on 30.
Yeah, patients who take Premix Insulin once daily can take the normal dose at iftar. If they take insulin twice daily, they can take the usual morning dose at iftar and reduce the evening dose maximum 50% and take it as sahur. And if they take insulin 3 times daily in dose, omit afternoon dose and adjust iftar and sahur doses. And see below a scheme where you can reduce insulin after you check blood glucose. So these guidelines are useful for you, and you can read this on the website. And for the outpatient, it's important to have a plan, okay? But it's important having a plan before Ramadan, okay? So the Ramadan is possible, but it's important choose the best therapy for the patient. It's the same for people with type 1 diabetes, that they have to reduce dose of long-acting insulin and short-acting insulin. But I suggest to not fast for type 1 diabetes, because the consequences are high, and because these categories of patients is a very high risk. So, summary and conclusion. So, patient taking Metformin, short-acting insulin secretagogue, sulfonylurea on insulin will need to make adjustments to dose and timing to reduce the risk of hypoglycemia. When you oral anti-diabetic drugs in your country is not used, but is in these guidelines is very useful. The classification, okay? So you can know if your patient is a very high risk, or it's allowed for him fasting. But type 1 of diabetes and pregnant women with diabetes need close medical supervision and focused Ramadan specific education if they insist on fasting. Obviously, a pre-Ramadan assessment is vital for any patient with diabetes, and educate the patient in self-management of the condition during Ramadan to produce a patient-specific treatment. And with the correct advice, pre-Ramadan period, and support from ACPs, most people with type 1 diabetes can fast safely during Ramadan. And a post-Ramadan follow-up consultation is recommended. So here are the diabetes practical guidelines, and you find on this website all the information I could speak to today for you. Thanks for your attention.
Thanks for you.
So,
thank you very much for comprehensive.
Scusa un attimo.
Sì. Yes.
Farà una sintesi della conclusione. L'inglese, la traduzione dopo. Ok.
شكرا كثير للدكتورة لورا والدكتور مارتن لإلقاء المحاضرة باللغة الإنجليزية. طبعا إذا بتحبوا نعطي ملخص بالعربي اللي حكى بالنسبة للتشخيص والتصنيف.
دكتورة حميدة الصوت بعيد، يا ريت الصوت يكون قريب أو أعلى أو أوضح.
Scusa, chiudete il...
أيوة. بالنسبة للملخص اللي قدم المواضيع اللي والتشخيص الأهداف طبعا اللي لازم كل النساء الحوامل كل النساء لازم انه يعملوا اختبار
cosa gli scriviamo? Ma questo lo leggono tutti?
طبعا يصوموا
no, per scrivere a tutti.
المرضى
perché se no scrivo
ممكن نسمع
connection difficult.
Scusate, chiudete il microfono per piacere.
Poi direi che ci sono domande.
Sì.
ايش صار؟
I think there was a question. مين عنده سؤال يا جماعة الخير بتحبوا ننقل له إياه للمحاضرة؟
السلام عليكم ورحمة الله.
وعليكم السلام ورحمة.
الدكتور طاهر شمتوت من مكتب التعليم والتدريب. طبعا يعني المحاضرة الله يعطيها العافية جدا مناسبة، وخاصة المحاضرة بخصوص رمضان، والجايد لاين اللي قدمتها الدكتورة كتير واضحة. أتمنى يعني إنه تكون مفيدة للجميع. بهمنا بس موضوع يعني جدا في المحاضرات إن شاء الله المقبلة في 25 و 26/6 إنه يكون الترجمة الأونلاين فورية، لأنه الشباب اللي حضرانين على الأونلاين كان عم بيصير في عندهم يعني بعض ضياع المعلومات، خاصة إنه هذه أول محاضرة بيحضروها غالبا في اللغة الإنجليزية. بعرف إنه يعني في المراكز اللي عم بيصير فيها حضور مثل الأكاديمية أو مشفى الأمل فيها ترجمة حاليا فورية من الأخوة، لكن يعني الترجمة الغير مباشرة مع الدكتورة ممكن يعني يصير فيها ضياع على الأخوة الحضور. فإن شاء الله يعني في المحاضرات المقبلة اللي حيكون فيها المحاضر أجنبي، فإن شاء الله حيكون يعني الترجمة مباشرة، يعني بيحكي الدكتور وبنفس الوقت بعديتها مباشرة بيترجم المحاضر. طبعا احنا كثيرين ما شاء الله اللي عم نحضر محاضرات أو عم نعمل باللغة الإنجليزية، فإن شاء الله كلياتنا حنساهم. ما بعرف أنا ليش اليوم الدكتور نبيل ما نجحت معه موضوع الترجمة، لكن إن شاء الله يعني مشان موضوع الشباب اللي عم يحضروا وعم يقولوا إنه مشان موضوع الترجمة إن شاء الله حتكون يعني هذه بداية تجربة، وإن شاء الله لاحقا حيكون المحاضرات في منها بالعربي وفي منها باللغة الإنجليزية. المحاضرات اللي بيكون المحاضر فيها يعني محاضر أجنبي ما بنحسن نخليه يحكي بالعربي، لكن بيحكي بالإنجليزي، وإن شاء الله يعني يعني بيتم الترجمة للعربي. وطبعا مثل ما حكينا هذه بداية التجربة. إن شاء الله ملاحظاتكم بإعادة التقييم من قبل المجموعة التقنية إن شاء الله، والدكتور نبيل بهمة الدكتور نبيل الله يبارك فيه إن شاء الله راح يعني تتحسن موضوع الترجمة. أتمنى أنه من مجموعة الإدارة إدارة المحاضرة أنه تكون المحاضرات جاهزة، بحيث أنه إذا سمحوا الدكاترة المحاضرين أنه نقدمها للأخوة الحضور مع شهادة الحضور. بارك الله فيكم. السلام عليكم.
وعليكم السلام ورحمة الله.
السلام عليكم ورحمة الله وبركاته. الدكتورة يا شباب حاطة اللي عنده سؤال أو شيء ممكن يراسلها على الإيميل وبترد على الأسئلة إن شاء الله في المحاضرات القادمة.
بدينا بالترجمة بس صار عندنا شوية عطل.
شكرا لك دكتور، وإن شاء الله الاتجاه الأفضل إن شاء الله.
نحن مشان
ممكن بالله إرسال سلايدات على الإيميل
للجميع
أو على الواتساب إذا ممكن.
بس سؤال، ما هو ممكن بس سؤال بعد
شو
تفضل أخي تفضل.
محمد الأسود من أكاديمية العلوم الصحية قسم الطوارئ. واضح الصوت؟
واضح.
تمام. طبيب جديد للسكري هلا حاليا، والجايد لاين للعلاج له. هو انا سمعت ان عم بقرا هلا انه في 5 انواع للسكري.
لا
5 تصنيفات.
تصنيف الداء السكري النمط الاول والنمط الثاني اللي كل بيعرفوه.
The question to Dr. Nolino is he's asking about, is there a new classification for diabetes? He's talking about 5 types of diabetes.
Ah boh, è già stato riabilitato. Puoi rispondere.
Okay, can I? Okay, so you asked me about the new classification. The 5 types of diabetes are a classification that has been proposed by a group of researchers of Northern Europe, but is not officially adopted by any guidelines. And in particular is a classification where there are some different subtypes of type 2 diabetes, differentiating by the endogenous insulin secretion. So we have different phenotypes of diabetic patient characterized by the insulin secretion, the endogenous insulin secretion, and by the body weight, but is not actually adopted by any international guidelines. So the classification that I show you is the actual classification proposed by the American Diabetes Association, by the American College of Endocrinology, and by the International Diabetes Federation. Do you listen me? Maybe or not?
Yes, thank you very much. We heard you very well.
Okay.
But I don't know whether anyone will translate or...
Okay. Don't worry.
Dr. Nabil, are you going to translate? Dr. Nabil راح ترجم ولا؟
يلا بيعطيكم الترجمة. اوكي.
الطالب رمضان أحمد الحسن من أكاديمية العلوم الصحية اختصاص الطوارئ. ممكن سؤال؟ طالب رمضان أحمد الحسن من أكاديمية العلوم الصحية اختصاص طب طوارئ. ممكن سؤال من فضلك؟
تفضل. بتحب تسأل
نعرف احنا اللي موجود عندنا انسولين قصير الامد وطويل الامد. وفي عندنا متوسط الامد. في عندنا انسولين بحيث انه يكون مدته طويله جدا بحيث انه يكون له كذا يوم فعاليته.
The question is saying that there is two types of insulin, broadly speaking, long-acting and short-acting. He's asking, is there a very, very long-acting insulin nowadays that lasts for a few days?
So I remind you that this part will be the argument of the last lesson, but long-acting insulin, like glargine, maybe is last maximum or 18-20 hours.
Doctor, can I translate with you online directly? Sorry?
Sorry?
Can I translate your answer directly?
Yes.
For online? I'm Dr. Tahir.
تحب الترجمة؟
Directly. دكتورة سيد. دكتورة سيد. الدكتورة حكت انه في عندنا يعني كما تكلمت في عندنا الانالجين يعني 24 ساعة إلى 36 ساعة. اوكي دكتورة؟
Okay, short acting, the analog short acting insulin lasts 3-4 hours.
بينما يستمر الانسولين السريع 3 إلى 4 ساعات تقريبا.
Instead, human insulin, rapid human insulin lasts 6 hours.
بينما يستمر الانسولين الانساني السريع تقريبا 6 ساعات.
واحد سأله على الانسولين بيقولوا انسولين الحقيقي.
The difference between short analog insulin and human rapid insulin is that short analog insulin is very fast, so you can take this insulin before you eat.
الفرق بين المماثلات أو مماثلات الأنسولين والأنسولين الإنساني أن مماثلات الأنسولين هي سريعة جدا، لذلك ممكن استخدامها مباشرة قبل الطعام.
The human rapid insulin need to take half an hour before eating.
بينما يجب أخذ أو إعطاء الأنسولين الإنساني قبل نصف ساعة من الوجبة.
But we talk about this part in this last lesson. We don't worry.
سوف نتكلم عن هذا الموضوع في الدرس القادم. لا تقلقوا حول هذا الموضوع.
If you are a lot of questions, maybe it's possible to write here, collect hold the question, and send us the question, and we will answer in the next days if you want by mail.
إذا كان عندكم يعني أسئلة كثيرة فممكن أنكم تكتبوها جميعها وترسلوها لها، وإن شاء الله في المرة المقبلة أو غدا ممكن هي تجاوب عليها وترسلها عن طريق يعني الموقع. اوكي دكتورة.
Okay, it's okay for you?
Yeah.
شكرا.
Okay.
شكرا دكتور.
اوكي.
Okay.
اوكي دكتورة.
So you. Sí.
Penso.
Yes.
Concluda.
Okay, so we'll see in June, the 25 and the 26th of June, for the next part of this course, this training.
نراكم إن شاء الله في 25 و 26 شهر 6 في الجزء الثاني من المحاضرات السكري.